Good morning everyone. Today's topic for discussion is intravenous induction agents. What are intravenous induction agents? These are the drugs when given intravenously at appropriate doses they cause rapid loss of consciousness. This rapid loss of consciousness is defined as one arm brain circulation time, that is the time taken for the drug to reach from the site of injection, usually the arm, to the brain, and it is usually 15 to 20 seconds. A small brief history of intravenous induction agents. First intravenous induction agent was hexobarbital, which was the ultra short acting barbiturate. It was introduced by Wies in Germany in 1932. Thiopentol was discovered by Lundy and Waters in 1935. Propofol was launched as Diprivan in 1986. Ketamine was discovered by Calvin Stevens in 1962. So what happens to the intravenous induction agent when it is given into the bloodstream? So the bolus of intravenous agent, it enters into the blood and it becomes either bound or unbound form. It enters the right side of the heart, from there to the pulmonary circulation, and then it enters the left side of the heart, from there to the systemic circulation. In the systemic, once it enters the systemic circulation, it follows a 3-compartment model where the drug first reaches the vessel-rich group, that is the brain, liver and the kidney. From there it shows the effect on the receptors, specific receptors for each drug, either GABA receptors or NMDA receptors. And then the drug diffuses to the tissues that have the less blood supply, such as skeletal muscle and fat. Once they reach these structures, the plasma concentration falls and the drug diffuses out of CNS. And this phenomenon is called redistribution. This leads to rapid wake-up after single bolus dose. And generally unbound lipid soluble and unionized molecules cross the blood-brain barrier the quickest. So what are the properties of an ideal agent? There are some physical properties and pharmacokinetic properties. The physical properties include it should be easily water soluble, it should be stable on exposure to light, should have a long shelf life, it should not produce any pain on injection, it should be non-irritant, and it should be available cheap. The pharmacokinetic properties ideally should include rapid onset, rapid redistribution, rapid clearance, and it shouldn't leave any active metabolites. So the drugs that we use commonly for induction are propofol, thiopentone, etomidate and ketamine. First we will discuss about propofol. It is a 2,6-diisopropylphenol. It is insoluble drug, so it requires a lipid vehicle for emulsification. So there are some commercial preparations that are available. It is available as 1% solution in an aqueous solution of 10% soybean oil. This soybean oil forms the oil phase for emulsification. It has 2.25% glycerol, 1.2% purified egg lecithin, which is an emulsifying agent, and it has a preservative, sodium metabisulfite. So other preparations are Diprivan, which is a disodium acetate, which uses disodium acetate as a preservative along with sodium hydroxide. Ampofol, which uses 5% soybean oil and 0.6% egg lecithin. This produces less pain on injection. Aquavon, which is water soluble, and Fospropofol, which is a prodrug. There is one more drug, Ciprofol, which is under study in phase 3 trials. It is an analog of propofol. So the mechanism of action is the propofol, it binds to GABA receptors in the central nervous system. Whenever the GABA receptors are when it attaches to the GABA receptors, there is a transmembrane chloride channel opening, and the chloride channel will cause hyperpolarization of the membrane. This leads to inhibition of the action potential propagation, and this causes sedation, anterograde amnesia, CNS depression, anxiolysis and muscle relaxation. The pharmacokinetic properties of propofol are: it is highly lipid soluble, has a pH of 4.5 to 6.4, it has a pK of 11, 98% protein bound, elimination half-life is 0.5 to 1.5 hours, onset of action is usually within one brain arm circulation, that is within 15 to 20 seconds, the duration lasts for 3 to 5 minutes when given intravenously. Metabolism mostly in the liver, it undergoes ring hydroxylation by CYP450 enzyme to 4-hydroxypropofol, and then it undergoes conjugation and glucuronidation and sulfation and is excreted by kidneys. In Clinical uses, or it can be used for induction of anesthesia at a dose of 1.5 to 2.5 mg per kg. Blood levels of around 2 to 6 mics per ml will cause unconsciousness. It is also used as IV sedation agent for conscious sedation, 25 to 100 mics per kg per minute, usually for GI endoscopic procedures. It is also used for maintenance of anesthesia at a dose of 100 to 300 microgram per kg per minute. It is also used in total intravenous anesthesia. It has an antiemetic property and given at a dose of 10 milligram followed by 10 mic per kg per minute of infusion. Chemotherapy induced nausea and vomiting can be reduced with propofol. It has antipruritic action with 10 milligrams IV. Anticonvulsant action when given at 1 mg per kg IV. Pharmacodynamics on central nervous system, cerebral blood flow is decreased, cerebral metabolic rate of oxygen is decreased, intracranial pressure is decreased, intraocular pressure is decreased. It has antiemetic and anticonvulsant properties. On the on the cardiovascular system, the BP decreases, heart rate is mostly no change, but it may lead to bradycardia in some cases. Respiratory system, it is a respiratory depressant and leads to apnea. When used as infusion for maintenance of anesthesia, generally the tidal volume decreases and the frequency of breathing also decreases. It inhibits hypoxic ventilatory drive. It also depresses upper airway reflexes. It is safe in asthmatic patients. On gastrointestinal system, it has an antiemetic property. Prolonged infusions will lead to hepatocellular injury accompanied by lactic acidosis, bradydysarrhythmias and rhabdomyolysis. The side effects include it causes pain on injection, so the vein should be chosen on the dorsum of the hand and it should be a bigger vein. And we can give even Loxicard before giving propofol to alleviate the pain. It causes hypotension, bradycardia, hypertriglyceridemia when given as a prolonged administration, and there is a potential for pulmonary embolism. It also has allergic reactions. The most fatal side effect of propofol is lactic acidosis or propofol infusion syndrome, mostly seen in children. On prolonged high dose infusion of 75 mics per kg per minute for more than 24 hours duration. Mechanism is by cytopathic hypoxia of electron transport chain and impaired oxidation of long chain fatty acids. Clinical features are usually unexplained arrhythmias, metabolic acidosis, hyperkalemia, rhabdomyolysis, renal failure, hepatomegaly, cardiac failure and hyperlipidemia. Diagnosis is mostly by ABG and also serum lactate levels serially. Treatment is discontinuation of propofol administration and cardiorespiratory support, if required hemodialysis. Bacterial growth is most common with propofol when used for when the opened vial is used after 48 hours. It supports growth of E. coli and Pseudomonas aeruginosa. So it should be discarded within 6 hours of opening. Next is thiopentone sodium. This is an ultra short acting barbiturate. It is available as a yellow amorphous powder with a highly alkaline pH of 10.5. Usually used as 2.5% concentration. Shelf life is 2 weeks. 1 ampule has around 500 milligrams of thiopentone sodium along with 6% sodium carbonate, which is an anhydrous agent. Mechanism is by the GABA-A receptor agonist, which increases transmembrane chloride transport and causes synaptic inhibition. Pharmacokinetics, it is 80% protein bound. Onset occurs within 30 to 45 seconds. Duration of action is for 5 to 10 minutes. It is eliminated with a T-half of 5.5 to 26 hours. Metabolism is mostly in the liver by oxidation and dealkylation, desulfation, which leads to destruction of barbituric acid ring and producing metabolites like pentobarbital, which is the active metabolite, which undergoes hydroxythiopental and 5-carboxylic acid, which are also inactive metabolites, which are water soluble and excreted by kidneys. The dose for induction is 3 to 6 mg per kg IV. For children, it is 5 to 7 mg per kg IV. In the treatment, it is used for the treatment of increased intracranial pressure and also for ischemic injury. It causes burst suppression and also cerebral protection. Effects on the organs. On central nervous system, there is dose dependent depression of central nervous system. Usually the end point of induction is loss of eyelash reflex. It reduces cerebral blood flow and also cerebral metabolic rate of oxygen consumption. It reduces intracranial pressure. It is a potent anticonvulsant and also anti-analgesic. It decreases threshold to pain. On cardiovascular system, there is fall in BP and cardiac output, which leads to reflex increase in heart rate. On the respiratory system, it will cause transient apnea, produces dose-dependent decrease in both tidal volume and minute ventilation. Medullary center ventilator response to both hypoxia and hypercapnia are reduced. It may not depress the airway reflexes well, so can cause laryngospasm and coughing. There is most common histamine release, which can cause bronchospasm. On the eyes, it causes decrease in intraocular pressure. It has an antithyroid effect as it inhibits the peripheral conversion of T4 to T3. Adverse effects include local necrosis when there is intramuscular injection. This causes ulceration. And inadvertent intraarterial injection of thiopentone, it causes intense vasospasm of arteries. So whenever it occurs, the first thing is stop further injection, keep the cannula in place, inject saline in the cannula to flush it and dilute the drug, and through the same cannula use a preservative-free lignocaine to reduce the pain, heparin to prevent thrombus formation, and papaverine to cause vasodilatation. Contraindications are absolute contraindication is acute intermittent porphyria because it inhibits the enzyme delta aminolevulinic acid in the synthesis of heme. So it can precipitate porphyria, so absolute contraindicated. It is also relatively contraindicated in people with sulfa drug allergy, asthma, hypotension, dystrophia myotonica and familial periodic paralysis. Next is ketamine. Ketamine is a phencyclidine derivative. It is water soluble. It is available as R and S isomers. Racemic mixtures are most commonly used. We have S-ketamine, which produces more intense analgesia, more rapid metabolism and recovery, less salivation, lower incidence of emergence reactions, and it has a preservative, that is benzethonium chloride. Mechanism of action. Ketamine shows its effects on many receptors in the central nervous system. It has channel effects in case of NMDA, HCN1, NHCA, NACH and L type of calcium channels. Neuromodulatory effects on glutamate, noradrenaline, dopamine, cortical acetylcholine, pontine acetylcholine, opioid receptors, neurosteroids, and also causes phosphorylation expression in stimulation. It also has effects on gene expression in case of GFAP expression, BDNF, cellular effects on synaptic homeostasis and apoptosis. So the main mechanism of action is NMDA antagonism. So this is an NMDA receptor. It has two allosteric sites and also the sites where the glycine and glutamate will bind. So whenever ketamine binds here, there is calcium channel conductance through the channel. Onset of action, it happens within 30 to 60 seconds and when given IV, but IM will take 5 minutes to act. Duration of action is for 10 to 15 minutes when given intravenously. Pharmacokinetics, it is 23 to 47% protein bound. Volume of distribution is 2.5 to 3.5 liters per kg. Elimination half-life is 2 to 3 hours. Clearance is 16 to 18 ml per kg per minute. It has a high hepatic clearance rate. Metabolism. Ketamine undergoes metabolism in the liver by demethylation to norketamine, which is an active metabolite. It is hydroxylated and conjugated to inactive glucuronide metabolites, which are water soluble and they are excreted by kidneys. Clinical uses. It is used for analgesia at a dose of 0.2 to 0.5 mg per kg intravenously, followed by infusion of 3 microgram per kg per minute. It is also used for neuraxial analgesia with an epidural dose of 30 mg or intrathecal dose of 5 to 50 mg, which is diluted with 3 ml of saline. For induction of anesthesia, for an intravenous route, we use 1 to 2 mg per kg. For intramuscular route, it is 4 to 8 mg per kg. Induction agent of choice in case of asthmatic patient, as it has a bronchodilatory effect. It is used in case of restless leg syndrome where it causes symptomatic improvement. It is also used for reversal of opioid tolerance. It is used for improvement of psychiatric disorders. It can be kept as an infusion at 1 mg per kg IV for 1 hour. And it is used as a bronchodilator at a dose of 30 to 40 microgram per kg per minute. As a sole anesthetic for short procedures in case of dressing of burns at a dose of 30 to 90 mics per kg per minute. Pharmacodynamics on the central nervous system, it increases cerebral blood flow, increases cerebral metabolic rate of oxygen, intracranial pressure and intraocular pressure. It also causes dissociative anesthesia where there is a stimulation of the limbic system and depression of the thalamocortical system. This causes a sense of dissociation for the patient where a patient cannot feel any sensory touch and he will feel as if he is floating on the air. CVS, sympathetic nervous system stimulation. It causes increases in systemic and pulmonary arterial BP, increase in heart rate, cardiac output, myocardial oxygen requirement. On the respiratory system, there is depression of ventilation but not significant. Upper airway reflexes are usually intact. Salivary, tracheobronchial and mucous gland secretions are increased. That is the reason we give an anti-silogogue before giving the ketamine injection. It has bronchodilatory effect. As discussed, it can be given in asthmatics, drug of choice. The complications are usually emergence delirium. This can be prevented by giving a benzodiazepine before giving ketamine. Hallucinations can occur, nystagmus, increased salivation, muscle rigidity, hypertension and tachycardia. The last drug is etomidate. It is an imidazole derivative. It is unstable in neutral pH solutions. It uses a solvent called propylene glycol and it can cause phlebitis and pain on injection. Mechanism of action is GABA receptor GABA receptor binding and causes activation of chloride channels, which leads to synaptic transmission inhibition. Pharmacokinetics, it has a pH of 8.2. It is 99% unionized at a physiological pH. Onset of action is within 30 to 60 seconds. Duration is for 3 to 5 minutes. Peak effect occurs in 1 minute. Protein binding is up to 76%. Clearance is 10 to 20 ml per kg per minute. It has an elimination half-life of 2 to 5 hours. Metabolism is usually in the liver by plasma esterases. It undergoes hydrolysis. There is a ethyl ester side chain which is hydrolyzed to carboxylic acid ester. This is water soluble and inactive and it is excreted via kidney. 2% of the drug is also excreted unchanged. Uses is for induction of anesthesia at a dose of 0.2 to 0.4 mg per kg intravenously. It generally causes hemodynamically stable induction, so used for cardiac patients, trauma patients and also hypovolemic patients where we don't want much of hemodynamical disturbance. Pharmacodynamics on the central nervous system, it causes decrease in cerebral blood flow, cerebral metabolic rate of oxygen and intracranial pressure. It activates seizure foci, so it has an epileptogenic potential. It facilitates localization of seizure foci. On the cardiovascular system, it is stable in the cardiovascular system, doesn't cause much increase in heart rate, BP or in the respiratory system, it causes transient apnea, it can cause cough and hiccups. It decreases intraocular pressure and it has increased incidence of nausea and vomiting on the gastrointestinal system. Side effects are pain on injection because of the propylene glycol that is used as preservative. It causes myoclonus, and the important side effect of etomidate is adrenocortical suppression. It suppresses adrenocortical system by inhibiting 11-beta hydroxylase, which is an important enzyme in the adrenocortical steroid production. It also has allergic reactions. This is a tabular form showing all the effects of each drug in a comparative form. Propofol, thiopentone, ketamine, etomidate and midazolam. Midazolam is also included in the tabular form just for comparison. So cerebral metabolic rate of oxygen is decreased by propofol, thiopentone, etomidate and midazolam, whereas ketamine increases it. Cerebral blood flow is decreased by propofol, thiopentone, etomidate and midazolam. Ketamine increases cerebral blood flow. Intracranial pressure is decreased by propofol, thiopentone, etomidate and midazolam. Ketamine increases intracranial pressure. Intraocular pressure is mostly decreased by propofol and thiopentone, not much effect with etomidate and it is increased with ketamine. Dissociative anesthesia is caused by ketamine. Emergence reactions are mostly seen with ketamine. Nystagmus is seen with ketamine. Skeletal muscle tone is increased with ketamine. Salivation and lacrimation are increased with ketamine. On cardiovascular system, there is propofol will cause much larger decrease in BP, around 25 to 40% compared to thiopentone and benzodiazepines. Ketamine will increase the BP. Etomidate is it is unchanged with etomidate. Heart rate, generally propofol inhibits tachycardic response to hypotension and may sometimes cause bradycardia. Thiopentone decreases heart rate. Etomidate increases heart rate. Heart rate is unchanged with etomidate. Benzodiazepines will increase the heart rate. Propofol will cause decrease in cardiac output. Thiopentone decreases cardiac output. Cardiac output is unchanged with etomidate. Ketamine increases cardiac output. So with this property, ketamine becomes the drug of choice in case of shock patients. Respiratory system. All the drugs will produce apnea, but propofol produces apnea in 15 to 20 seconds. Larger doses of ketamine will produce apnea. Rapid injection of etomidate can produce apnea. Ventilatory drive is markedly decreased with propofol and thiopentone. It is minimally decreased with ketamine and etomidate. Bronchodilation is marked with ketamine. Minimal bronchodilator effect is seen with propofol. Airway reflexes are decreased with propofol. Thiopentone, ketamine and etomidate will keep the airway reflexes intact. So the uses, all the drugs can be used for induction. All propofol, thiopentone, ketamine, etomidate and benzodiazepines, they can be used for induction. Except thiopentone, all the drugs can be used for sedation. All the drugs can be used for maintenance of anesthesia. Most commonly used is propofol. Analgesic property is more with ketamine. It is a potent analgesic, so can be used for short procedures like burns dressing. Preemptive analgesia is marked with ketamine. Antiemetic properties are good with propofol when given at a dose of 10 mg per kg IV. Antipruritic properties are with propofol at a 10 mg IV dose. Anticonvulsant property is seen with propofol, thiopentone and benzodiazepines. Etomidate has got epileptogenic property. Chronic headaches are seen with propofol when given as infusions. Amnesia is marked with ketamine. It is also seen with propofol and benzodiazepines. Thank you.